Good morning. Welcome to our Grand Rounds talk. Thank you all very much for coming in person. As always, we really appreciate the physical presence. We of course appreciate those who are on Zoom, but it really makes a difference to see faces in the crowd. So thank you all very much for making the effort to attend today. Today's talk is sponsored by the Longer Life Foundation. So I'm going to hand it over to Dr. Zimmerman to give you a little introduction into that before we turn it over to Dr. Kory Lavine.
Hi, well, good morning, everybody, and welcome to Grand Rounds. And as noted by Dr. Socius, I am Dr. Dan Zimmerman, and I lead the Longer Life Foundation, which is a collaboration between Washington University and the Reinsurance Group of America located out in Chesterfield. Now in its 24th year, and yes, we'll be celebrating our 25th anniversary next year, the Longer Life Foundation's mission is to fund and support the study of factors that either predict the mortality and morbidity of select populations or influence improvements in longevity, health, and wellness. Since 1998, we have funded over 137 research grants here at WashU. The Longer Life Foundation will soon be publishing our 2023 call for applications, and we will be hosting an in-person question and answer session for prospective grant applicants on January 25th from 12 to 1 p.m. We have some flyers around, so if you want to pick some of those up, they're outside at the table. And we'll also be posting that on the internet and so forth at WashU, as well as the Longer Life Foundation website. It's going to be held at the Farrell Learning and Teaching Center, room 205, and lunch will be served. And I can repeat that again, lunch will be served. So if you can reserve ahead, we can make sure we have enough of the box meals. Again, there'll be information about how you can sign up for that. With that, I would like to turn things over to Dr. Dominic Reeds. He's the Associate Professor of Medicine and Medical Director, Nutrition Support Service at Barnes Jewish Hospital. He also serves as Director of the Longer Life Foundation's Longer Life Center, which is located here on the WashU campus. Thank you, Dominic.
Super, thanks, Dan. The Longer Life Foundation is a great organization. They provide about $600,000 a year in funding to the center. So for junior faculty, this is a superb place to get off the ground. Kory Lavine was one of our, I would say, level guys who we funded, and we have a really good track record of picking the right people and trying to help you. With that said, without taking any further time away from Kory, his background, I always forget you did a BS in cell biology at the University of Rochester, where I did my training, and then he came up here and did an MSTP for his MD PhD and has completed fellowships in cardiology and heart transplant cardiology here. In addition to being a fabulous guy and a fabulous soccer player, he's just a wonderful person and wonderful mentor for junior faculty. And so I really look forward to your talk today, Kory, on precision medicine for inflammatory heart disease.
Well, thank you very much for the kind introduction. And thank you to Dan, the Longer Life team, or Longer Life Foundation team, for hosting this event and their generous support over the years. So I'm going to talk today about a new initiative that we've been pursuing within our laboratory and our research center, and that's using precision medicine for treating inflammatory heart diseases. These concepts and projects were actually born out of the support that we got from the Longer Life Foundation. And it's a project that's really exemplified and continues to be highlighted within our research program. All right, so I have no relevant disclosures for this talk. I received some consulting from Medtronic, Flame, Implicit Biosciences, and Conixa, and have some industry-sponsored grants, but none of these are relevant for today's talk, and that's officially certified. So the outline of what I'd really like to talk about today is I'm going to begin by talking about opportunities to target inflammation in heart failure and focus on innate immunity. I'm going to then discuss and introduce the concept of implementing precision medicine paradigms in cardiovascular research as a new investigational tool and translational tool. And then talk about one of the targets that we've identified using that approach, which is a type of innate immune cell, which we think drives inflammation in several forms of heart disease. And then end with a discussion how we envision using precision medicine to translate these concepts and discuss some of the indications and clinical development pathways that we're pursuing. All right, so to begin, I wanted to review a little bit about what we know about heart failure and use that to frame our discussion. So most people believe that heart failure begins with an index event, and that index event acts as an injury or damage to the heart. And that's easy to conceptualize when you think about heart attack or myocardial infarction injuring the heart, but it can be a variety of different pathologies and diseases. It could be a viral infection, exposure to chemotherapy, exposure to things you're not supposed to do, like cocaine, or even the genetic expression of a previously silent trait. And that index event essentially acts as an injury. And I think we've all seen patients in the CCU or within the cardiology firm where some individuals will have quite a bit of cardiac injury, but will subsequently recover. And this is fantastic for those patients, but this is not seen very often. The majority of patients will instead undergo this process called remodeling or adverse remodeling, which is visualized on an echocardiogram as the progressive dilation of the heart and thickening of the walls or cardiac hypertrophy. And on the tissue level is exemplified by fibrosis, the enlargement of individual cardiomyocytes, and the loss of vascular tissue. And this remodeling process really is the target of almost all the therapies we have for heart failure. Angiotensin inhibitors and receptor blockers, beta blockers, aldosterone antagonists, neprilysin inhibitors, and maybe the target of SGLT2 inhibitors. And with those therapies, cardiologists think we do really, really well with all of our large clinical trials. But the reality is, with the introduction of these therapies, we really achieve disease stabilization, and only a minority of patients will recover cardiac function or achieve reverse remodeling, which is essentially just an incomplete improvement in cardiac function. And so we still have a ways to go. We really do very little about targeting the index event or why the heart actually fails outside of treating coronary artery disease where we revascularize the heart. We do exceedingly little about treating underlying causes, whether those are genetic causes or underlying autoimmune or autoinflammatory diseases. We really have an incomplete understanding of remodeling and a poor understanding of what drives recovery and reverse remodeling, other than knowing that it is a possibility. And so we're still in search for important new disease mechanisms to target. So one of those mechanisms that our group has been interested in and focused on is inflammation. And I think this is really nicely highlighted by just looking at a few histology images of different cardiovascular diseases. And so if you look at basically just stock histology images and look for immune cells, which are essentially these little blue dots, there's immune cell infiltration across all different forms of heart disease and heart failure. Of course, we see it within myocardial infarction at the time of the injury, but we see it chronically in those patients too, either within the infarct or within border zone areas near the infarct or remote from the infarct. We see collections of immune cells in other cardiac diseases that are gaining increasing recognition, like cardiac sarcoidosis, both acute and chronic viral myocarditis, and even genetic forms of heart failure like rhythmogenic cardiomyopathy and non-ischemic cardiomyopathies that are driven by mutations and components of the cytoskeleton. And so these immune cells really are present throughout all of these conditions. So what's the evidence that inflammation could be important for heart failure other than these cells are present? Well, one of the things that immune cells do is they make a lot of inflammatory mediators, and those are generally termed as cytokines and chemokines when we think about proteins, but there's also a lot of carbohydrate and lipid mediators that they make. And there's really a plethora of data out there that if you measure serum levels of these chemokines and cytokines, that they're associated not only with myocardial infarction and heart failure, but they're also linked to clinical outcomes. So this is one example. This is on the y-axis, serum levels of TNF. And on the x-axis is NYHA functional class. The higher the functional class, the worse that patients are doing. And you can see that TNF concentration in the serum is positively associated with poor functional class. And the amount of TNF measured at a certain time point is also prognostic of how a patient could do and is predictive of mortality, just as one example. But despite this information, early clinical trials that have really focused on targeting some of these inflammatory mediators by repurposing a lot of therapies really from the rheumatology world have produced either modest or disappointing results. So some of the agents that have been tested early on were things like steroids, which broadly suppress the immune system, cyclosporin, which inhibits T cell receptor signaling, TNF antagonists, IL-6 antagonists, either produce disappointing results in the case of cyclosporin and TNF inhibitors, or just modest improvements like what was seen with steroids and most recently IL-6 receptor neutralizing antibodies. And I think one of the issues in this area is that the actual cell types that make these inflammatory mediators in cardiac inflammation really remained unresolved. And we don't really know which of these mediators is driving disease. And so while there's a potential to target inflammation, it really remains an unmet clinical opportunity in an area that I think could be explored to develop new therapeutics. So one of the glimmers of hope for inflammation and that really re-energized this field was the Kanto study. And I'm sure this has been reviewed in lots of different grand rounds. This was a study that looked at canakinumab, which is an IL-1 beta neutralizing antibody in patients who had a prior ischemic event, usually coronary artery disease or myocardial infarction or something like that, and looked at their clinical outcomes. And so this study was pretty large, included thousands of patients with different doses of canakinumab. And there was a dose-dependent reduction in poor cardiovascular outcomes, heart failure hospitalizations, non-fatal MI, stroke, angina requiring revascularization, all-cause mortality. So placebos in black, and then increasing doses of canakinumab with the lowest dose in green and the higher doses in blue and red. And so this provided new hope to the field. But this study in reanalysis also really exemplified why precision medicine approaches are going to be necessary to successfully implement anti-inflammatory therapies. And so when this study was reanalyzed to try to separate patients that responded to canakinumab from ones that didn't, using change in CRP, an inflammatory marker, as a surrogate for response. This is probably one of the most, I think, striking forest plots you'll see. The only patients that responded to this therapy or received benefits were patients where the CRP was reduced, which tells us two things. It tells us that in this population of patients, it's heterogeneous, and there's likely multiple mediators driving inflammation in their clinical outcomes. And only some patients had IL-1 beta as their main driver. And the second thing it tells us is if we're able to identify the patients that would respond to IL-1 beta, we could actually successfully treat the right patient with the right drug. And those are really the concepts of precision medicine, to take individual diseases that are heterogeneous and divide them into categories based on disease mechanism and to match the right therapy with the right patient. And so this is a concept that in some ways needs reimagination of how we approach investigation and how we approach clinical trials to really realize its potential. And so I'm going to highlight that by talking about some of our traditional approach to investigation and how that really could be revamped by these precision medicine concepts. So the way I was trained, which is not that long ago, to do basic and translational science. And what we did really in my lab up until a few years ago was to do discovery and disease models. And what that means is that you would identify a model of the disease of interest. Could be a mouse, could be a zebrafish, could be a fly, could be cell culture, and then take that model and dissect it and try to learn something new to identify a new target or a new mechanism that you could exploit. But there's a problem with that, in that the targets and mechanisms you identify are influenced and biased by your past experience. You pick things you know about. It's biased by what's in the literature. So you're kind of playing poker with the same cards that everyone else played with. And it's biased by the experimental model. So if your model is not a good model, you're not really set up to succeed. And at the end, if you're successful, you then hope you're relevant to the human disease. And so I think you can see very clearly why this approach could fail. And it has failed in a number of different disease kind of spaces. But it's also succeeded. And so I don't want to take away from that. So Gleevec, which we use to treat CML and was the parent to a lot of other RTK inhibitors, tafamidis for amyloidosis, all come out of this sort of scientific paradigm. So it has been successful, but there are ways to hone it and make it better. And I think the main fallibility of this is that we're doing discovery in a model rather than doing discovery in the actual disease of interest. And so in about 2018, 2019, we really embraced this issue and wanted to come up with new ways to think about inflammation and heart disease and how to change our paradigms in our research model. And that was fueled by new technologies. And so new technologies today are available to actually do discovery in the human disease of interest. And I'm not going to go through the nitty-gritty of these technologies, but I'm just going to give you a smattering of some of them. One of the, I think, breakthrough technologies is single-cell RNA sequencing, and now there's derivatives where you can look at epigenomics, you can look at proteomics, you can look at all sorts of different things. And what these technologies do is they allow you to understand what is the cell composition of a disease tissue, and what are the cells that may be associated or emerge in the context of disease, which could be a target. We have technologies that now can do similar analyses simply on histology sections that may have been in the pathology warehouse for decades. And so you can do a similar type analysis where you can map in space where these disease-associated cells are, what are they making at the RNA and at the protein level. We can do biomarker studies today with not just looking at 5 or 6 biomarkers, but looking at thousands or tens of thousands at a time using aptamer technologies or mass spec technologies. Probably one of the most impactful new approaches that's been employed over the past decade or two is human genetics, being able to identify variability in genes and causally link those to diseases and disease progression, which gives immediate clinical relevance. And then lastly, we can now make therapeutics in the academic environment using new technologies, both at the small molecule and biologic level. And I'll talk about one of those, DNA-encoded chemistry. And so with these new technologies in hand, we set out to try to reimagine how to approach investigation in cardiology and inflammation. And this is the initiative that was born thanks to support from the Department of Medicine and the university, and that's the Cardiovascular Precision Research Initiative. And our goal is to define disease at the patient level, to split those diseases into mechanisms that can be targeted, use human tissue for discovery, create hypotheses about mechanisms that drive the disease, to try to test those mechanisms in the appropriate experimental model, and then develop approaches to target those mechanisms for patients, which requires 2 elements. The first one is to create diagnostics that allow you to look at a patient without taking their heart out and say this mechanism is driving their disease, and then having an appropriate therapeutic that targets that mechanism. And so this, the success of this approach is really driven by step 1, our ability to define disease at the patient level. And that's fueled by the technologies I shared on the prior slide, but you also need the human specimens to do this. And so I was fortunate to be part of the Center for Cardiovascular Research, where in about 2010, Gene Bone initiated our heart biobank, where we've been collecting explanted heart tissue from LVAD recipients and transplant recipients. And we now have, I think, over 1,000 tissues from both children and adults that underwent those procedures at our institution. And I've had the privilege to expand that biobank to collect muscle and coronaries and valves, blood samples, and to link our protocols with other biobanks across the country, such that you can do studies on rare diseases where you can pick a few from different institutions. And that's an effort that's driven by Cameron Jones, Rebecca Miller, and soon to be handed over to Antonisha Parks and Joel Hands. The other, I think, important source and tool we have is amazing registries that we continue to build here. So Doug Mann, when he came to WashU, started an adult heart failure registry. We have rich clinical data and blood for biomarker and genetic analyses. And we've been able to expand that to include other populations, the pediatric population, heart transplant population, LVAD population, and even the post-acute COVID-19 population. And these are resources that are made available across the institution. Okay, so in the subsequent slides, I'm going to talk a little bit about what we've been able to do over the past few years with these technologies at hand and this new way of thinking. And so the first question we asked were, what are the actual immune cells that exist within the different forms of heart failure? And to address that question, we turned to the single cell sequencing technologies that we used on both fresh tissue as well as archived frozen tissues some decades old. And what we learned is that the failing heart really contains two major types of immune cells: monocytes and macrophages, which is an innate immune cell that's often associated with inflammation, and largely T cells with a subset of NK cells. I have to mention that because Wayne would not be happy otherwise. He's one of the main pioneers in discovering NK cell function. And there's also a smattering of other immune cells within the heart, mast cells and B cells. But by and large, monocytes and macrophages are the predominant population. If you stain any 20x or take any slide and take a 20x image, you can find macrophages, which are shown in green here, numerous numbers of them in any section. So they're really predominant. And one of the other things that these studies told us is that there wasn't one type of macrophage, but several types. And they could be roughly divided into two populations. And I'm going to tell you about those now. So what we learned was that these innate immune cells that exist within the heart can be subdivided based on developmental origin. And they actually come from two lineages. One we're all very familiar with and understand. And these are macrophages that come from monocytes that are derived from the bone marrow. They originate from definitive hematopoietic progenitor cells, typical HSCs that make all the blood cells, and they hone to tissues during times of injury, stress, disease, and infection. And we can identify them in all sorts of mouse and human tissues based on the expression of one cell surface marker, CC chemokine receptor 2, or just CCR2. But what we didn't appreciate, and the field didn't appreciate at the time, was that there was another source of macrophages. And these are macrophages that came from the embryo. They seeded the heart during development, and they lived in the heart completely independent of monocytes, this other population. And these macrophages came from a different hematopoietic progenitor that's restricted. They only can make red blood cells and myeloid cells and never make T or B cells. And we could distinguish these macrophages from the monocyte-derived macrophages because they did not express CCR2. And so when you look in heart tissue from humans or from mice, the majority of macrophages that are present express low levels of CCR2 and come from the embryo. And the minority of macrophages express high levels of CCR2 or come from the bone marrow. But if you look at disease tissue, that's flipped, and that the CCR2 positive macrophages will predominate. And these cells have very different dynamics and functions. So the CCR2 negative macrophages that come from the embryo, they're long-lived, they're a tissue-resident population. If you take patients that were transplanted and look at their hearts 20 years later, those cells are still there. So they're very long-lived. They're maintained independent of monocyte input, and they play roles in homeostasis and tissue repair. And they're helpful. CCR2 positive macrophages, on the other hand, are completely different. They're maintained by monocyte recruitment. They accumulate in the injured and diseased heart. They have robust inflammatory and oxidative potential. They injure tissue, and they're associated with and causally linked to heart failure progression. And you can see immediately, if you have a therapy like steroids that target both macrophage populations, you could have benefit and harm at the same time, that you want to really precisely target the disease-causing population. So I'm going to summarize what we've learned about these populations over time, just to give you a sense of what they do. So the CCR2 negative macrophages are the cells that come from the embryo that are tissue resident and long-lived, do everything that you would not think a macrophage or immune cell does. They play roles in tissue regeneration, in the development of the coronary vasculature and its growth, like forming collaterals. They play roles in modulating metabolism by clearing mitochondria from damaged cardiomyocytes. They facilitate conduction through the atrioventricular node. They're important for repairing the heart, and they're actually one of those mediators of cardiac recovery. that I mentioned earlier. They restrict leukocyte recruitment and inflammation, and they even can suppress transplant rejection. So they're really a protective population that we want to spare and could be the target of regenerative therapies. On the other hand, the CCR2 positive macrophages, the ones that come from monocytes that are recruited from the bone marrow, are very different. And so they're shown in green here. They sit within the myocardium. They send little arms into the interstitial space and live there. And what they do is they're patrolling and they're looking and sensing injury. And they get activated when cardiomyocytes are injured or died. And they initiate inflammation by secreting a lot of those inflammatory mediators, chemokines and cytokines, and other lipid products that are associated with heart failure severity, as well as prognosis. And I'll show you in a second that the generation of these mediators occurs through a defined and targetable pathway. And so through these mechanisms, this population of CCR2 positive macrophages functions to govern recruitment of other leukocytes like neutrophils and monocytes that potentiate inflammation and damage to the heart. And they're both associated with and causally linked to heart failure progression and pathogenesis in both patients, and causally linked to heart failure and damage in animal models. So these cells don't live in isolation. They live in a neighborhood and environment like every other cell. Anyone interested in oncology in the room knows about the tumor microenvironment, that the environment these cells live in influences their function. And understanding that can give you insights into new therapies. And so I'm not going to go through the nitty gritty of this, but just highlight the main points. Using some of these newer technologies and computational adaptations, we can perform single cell sequencing to identify all these different subsets of immune cells within diseased tissue. We can do spatial transcriptomics to understand where they live and map this data together. When we map this data together, we can create cell neighborhoods. We can ask within defined regions that are about 40 microns in size, what cells are present, and localize those to sites of disease. And what we learn from this is these CCR2 positive macrophages live in a neighborhood that contains activated fibroblasts and T cells and some NK cells. And signaling between these populations is important to maintain these disease-associated neighborhoods. And some of those signals that occur within these neighborhoods include JAK-STAT signaling, which is commonly activated in response to cytokines, TNF signaling, and NF-kappa B signaling, which could be targets for therapy. So we can now, take this human discovery and build these hypotheses and begin testing these in mice. And to do that, you want to focus a little bit on what do you want to test and make sure that there's a therapeutic runway for doing that. And so we focused on two mechanisms. One is if we understood how these macrophages get activated, and we could develop inhibitors to those pathways, right, and prevent inflammation. And so we spent a lot of time understanding how these CCR2 positive macrophages get activated, identifying some of the receptors that are upstream of their activation, toll-like receptor and IL-1 receptor. And the important point I want to make is each of these receptors converges on a common pathway. This MyD88 IRAK kinase adapter and signaling component that can be targeted for therapeutics. The other approach that we've taken is thinking about what these cells make. And if you can understand the cytokines and signals that they make, one could develop neutralizing antibodies to try to inhibit them to improve outcomes. And those are the two mechanisms or sets of mechanisms that we've been exploring in appropriate mouse models. And so this is one of the mouse models that we use. This is a myocardial infarction model in mice. We essentially use a model that recapitulates what we see in the cath lab. So we take animals and we subject them to 90 minutes of ischemia of the left coronary, then we reperfuse, and then image them 4 weeks later to look at infarct size and alveolar modeling. See if I can get this to play. There we go. And so if we take a control animal and infarct it and look 4 weeks later, you can see that there's a nice infarct. And you can see that the LV dilates a little bit and the function drops. Ejection fraction ends up usually being 35 to 40% in this model. And if we make any of these manipulations, which include removing this macrophage population, inhibiting its activation by deleting MyD88 in it, or preventing the production of IL-1 beta and another chemokine CCL17 that they make, you see marked improvements in function. You see a smaller infarct, you see smaller chamber volume. It's currently in asystole, there you go. And then you see improved cardiac function. It does not cause bradycardia. That's a Zoom artifact. And so if you look, and you can look at pathology and you see less inflammation, you see smaller infarcts, less fibrosis, and improved function. And from a molecular level, when you go in and analyze these tissues, those neighborhoods I talked about where these macrophages live and communicate with activated fibroblasts and T cells are disrupted. And so we really think we have a potential target for therapies that can not only improve outcomes, but hit the mechanism of action that we're so interested in. But there's also additional opportunities that we're exploring in the lab that I just want to mention. So I talked about this dichotomy of the CCR2 negative and positive macrophages. And it turns out that these CCR2 positive macrophages aren't one population, but represent a compilation of many populations that each perform different functions. And that's important because when you look across different diseases like myocarditis or genetic forms of inflammatory cardiomyopathy or autoimmune forms of heart failure, different populations of CCR2 positive macrophages are really predominant. And it may be important to target them individually. And some of the ongoing work in our lab that's very exciting is trying to understand what the environmental cues are, exposure to different signals or debris or cell contacts or intrinsic mechanisms like hypoxia sensing or clonal hematopoiesis. Which one of these influence these fate decisions, which would give us a new opportunity to target these populations beyond just their activation and effector cytokines. So I want to turn now to, once you identify a mechanism, what can you do about it? So oftentimes as a basic and translational scientist, the buck stops there, right? And then we have to hand over to pharma or find a partner to develop therapies. And that's a little, I think, disconcerting. And the dream for most physician scientists is to discover a mechanism and then be able to translate that and get it into patients. And so over the past few years, it's become evident that finding small molecules and making drugs can also be done in the academic environment. And so when most people think about drug screens, they think about going through stacks of 96 well plates and having 400 people do this for over 3 years to try to find compounds that inhibit a target's activity. But there's new ways to do this using sequencing technologies that are very adaptable to the academic environment. And this is one of them. It's called DNA-encoded chemistry. And so these are libraries of compounds that are tagged by a DNA barcode. Essentially acts as a barcode. So when you sequence it, you can look through your catalog and say what molecule is attached to this barcode. And so these libraries contain billions of compounds, with each has a unique DNA barcode. And that's different than commonly screened libraries in pharma, which only contain hundreds of thousands of compounds. So you're already many orders of magnitude above what's being screened in the private sector. The other advantage of these libraries is they're new chemical entities. They're new cards in the game, and they're usually chemical structures that haven't been worked with before. And what you essentially do is you take your target protein. In our case, there were those IRAC proteins that are important for the activation of this macrophage population. You mix it with this library, and you essentially do a pull down assay, which is done in a test tube that's literally this size. And you sequence the barcodes that come down with your protein of interest after a lot of wash steps. And this can give you your lead compounds. It essentially allows you to identify the needle in the haystack of compounds that may bind your protein. And these compounds can do a lot of things. They can modulate activity if you're looking at enzyme or a kinase, but by simply binding to the protein, you also can tag them to proteasomal degradation chemical moieties and essentially put them in the proteasome, which is the cellular trash. So that's kind of like how thalidomide works. So we did this with the IRAC complex and screened it. And we actually immediately found a series of compounds that inhibited the IRAC kinase activity at 10 nanomolar affinity, which is the affinity that sometimes takes years to find through traditional chemical libraries. And all this was done over a span of just a few months. And we've now gone through and improved these compounds to improve their solubility to some degree, improve their metabolism, which is still ongoing work, and been able to show that they have activity in cells and can also prevent inflammation in animal models. And so we're currently working to further develop them and test them within our mouse injury models. And that really only took really a year or two. This set of compounds inhibits the entire IRAK family. IRAK4 inhibitors are actually already in phase 1-2 trials for oncologic and some autoinflammatory diseases, but there's never been a compound tested that inhibits the entire IRAK family. And we're working with a novel chemical core, which is good for IP and has multiple opportunities for modification. The other type of therapy that can be used, I think, and developed in the academic environment is antibody-based therapeutics. I think this has been known for a while, but antibody-based therapeutics, I think we're all getting increasingly comfortable with in our day-to-day practice, used for treating, lipid disorders, the PCSK9 antibodies, used in rheumatology probably before I started training. That now the rest of the, I think, medical community is getting very used to using these in our practice. And so antibody-based therapeutics have a few advantages. One, they're kind of natural. And so you're not going to get a lot of off-target effects beyond injection site reactions. They can do a few things. They can neutralize signaling, so they can prevent ligand receptor interactions. We can use them to get rid of cells, to deplete cells, so you can edit the cells that are within a disease state. So if you find a disease-causing cell, it could potentially be removed with an antibody, similar to how rituximab can remove B cells across oncologic and rheumatologic applications. And we can also do this with bispecific T-cell engagers. And they also provide a promise for targeted drug delivery. So one of the problems with small molecule therapies is they have on-target but undesirable effects by inhibiting signaling in cell types that you're not interested in. And so antibodies provide a means to deliver your therapy to the cell type of interest by tagging the antibody and linking the antibody with your drug conjugate. And this is one that we've developed. We developed a CCR2 nanobody. An antibody is essentially the red part of the antibody here, which is the variable chain. So it's smaller, and we've linked it with different drugs. And one of the drugs that we're working on the linker for is our IRAK inhibitor. And this is when you do that, the antibody binds your cell of interest, it gets internalized, and the drug can get released in the endosome by proteolytic cleavage of your linker. So it gives you a way to deliver your drug to the cell type of interest and elute that drug once the antibody or nanobody is internalized. And that's how we envision using our IRAK inhibitor in the future. Let me skip this here. So once you get to that stage, how could you implement these immunomodulating agents using precision medicine techniques? And this is an area that I've gotten a lot of mentorship from Doug Mann and Phil Needleman on really how to do this. Doug has really been instrumental in the translational growth of our cardiovascular research program within our division. And those who don't know Phil Needleman, he was a professor and chair of pharmacology here years ago and had a tremendous career in pharma and continues to be an amazing friend to the university and mentor for young scientists interested in translating their work. So in our context, we're interested in the following patient pool: patients who've had an MI, those with heart failure, those with different forms of myocarditis, or ventricular arrhythmias sometimes are associated with inflammation. And that's our pool of patients. But we need to select patients that are most likely to benefit from therapies that target the CCR2 positive population. And one could do this with biomarkers, but the method we've developed is molecular imaging. So we actually can see the cells that we're interested in patients without having to biopsy them or take out their heart. And then we can deliver the right therapy to the right patient. So I'm going to talk in the remainder of the time about our molecular imaging program to identify these CCR2 positive macrophages, and then end by talking about some concepts around patient selection and disease indications where inflammation could be quickly taken up into the clinical landscape. So we've developed a CCR2 radio tracer to identify this population of macrophages in patients. This was done with Youngjin Liu, who's a radiochemist in radiology, and Rob Groppler, who's an imager within both radiology and cardiology. What we did together about 5 years ago is we identified a peptide that binds to a side pocket of CCR2. It doesn't influence its biology or function or signaling, and conjugated it to this moiety here called DOTA, which is essentially a chelator for radioactive metals like copper or gallium that we use to see the PET probe. And this probe binds to CCR2 and CCR2 positive cells with an IC50 of about 60 nanomolar. Peptides are ideal for imaging because they're quickly removed from the system. So you have low radiation exposure and they have fast on and off rates. So they're cleared from the system quickly. And so we've gone through animal models with this, but I'd like to share some of the human data that we've completed recently. So these are patients that had an ST elevation myocardial infarction, and they were imaged with our CCR2 radio tracer to see if we can, if the tracer essentially works. And so this is our imaging protocol. These are healthy subjects, start up here. They undergo a SPECT CT, which is technetium, to try to see the myocardium. So this is the healthy myocardium here. And then they undergo a CCR2 scan with our PET probe. And so in a healthy subject, you have the entire myocardium lights up, and the CCR2 tracer doesn't have any uptake. But if you look at patients who've had a myocardial infarction, this is a patient in anterior STEMI 4 days ago. You can see the area of infarct by the green arrow and the lack of uptake here. And our CCR2 tracer is taken up within the infarct and within the border regions, as we would expect. One of the things that we didn't expect from the study that we learned is that unlike animal models, inflammation is persistent in humans for months after their myocardial infarction. So for many patients, after the first few weeks, we saw persistent CCR2 uptake into the infarct. And for some patients that had persistent dysfunction, even months after their infarction, we think everything's cooled off. They had persistent uptake, not only within the infarct shown in the red area, but also outside the infarction as well, which tells us there's a population of patients that are likely to have persistent inflammation that could be a good target for this therapy in the ischemic disease category. This is some of the quantitation of the data. What I want to show you is between control, which is healthy subjects, and the infarct of STEMI patients, there's no overlap of data points. So this is clear signal, and you don't see that signal in other muscle tissues in the body like skeletal muscle here. And this is the data that the signal is persistent over a long time. So we're now designing studies and executing them to define the natural history of CCR2 positive cell accumulation in various forms of heart failure. We're doing MI, we're now doing cardiac sarcoidosis, which has been quite interesting. And we're going to expand to include this other entity I'll talk about in a second, arrhythmogenic cardiomyopathy. We want to use it to evaluate patient heterogeneity. What's prognostic? Is it the amount of signal? Is it the location of signal? Is it the duration of signals present after an injury? And the goal is to use this tool to efficiently implement immunomodulatory therapies. So what indications could you could target outside of MI? So myocardial infarction is like the obvious one to start with, but the one thing that we sometimes forget is we're pretty good at treating MI. It's rare to see a patient actually pass away from an infarction in the CCU or in the hospital once they've been revascularized and cared for. And many patients heal and do well. And so to really translate that will require 1,000 or so patient study because we have pretty good background therapy, even though we could do better. But sometimes we forget there are diseases out there that we really stink at taking care of. And so one of those up to a few years ago was recurrent pericarditis. I don't know if anyone's seen a patient with recurrent pericarditis. Maybe one, I've seen like 5. It's not super common, but it's really hard to treat. And for those patients, they get relapsing chest pain that's debilitating for them, despite using things like NSAIDs or colchicine or steroids. If you take that population of patients and look at recurrence rates, it's like 100%. It happens all the time and they get steroids on and off. And so this was one of those spaces where there was no therapy. And so there was a company called Kiniksa who had an IL-1 trap that they licensed from Regeneron. And Regeneron had failed in every indication. And they thought, well, this could be an interesting indication. And they tried it. And the response rate, this is the response rate. You can't argue with that, right? It's huge. And so the lesson is, there's 2 lessons from this. One is if we consider using diseases that we aren't very successful at treating, we can actually have a pretty big impact on patient care, but it's easy to show efficacy, right? And it's a major unmet clinical need. And only people in the front can see this, This was a trial that had 61 patients, 30 in the placebo group, 31 in the placebo group, and 30 in the rilonacept group. And it achieved FDA approval with this, and now is the standard of care for recurrent pericarditis, and it's quite effective. So are there other diseases like this that could be tried for inflammation that involves the myocardium? And one of those is arrhythmogenic cardiomyopathy. So arrhythmogenic cardiomyopathy is a not so rare, but also not common, genetic form of heart failure. It's characterized by cardiomyocyte loss, fibrosis, and the key element that's in every textbook that's on board exams is adipocyte dysplasia, so fat cells that you're seeing within the myocardium, mostly within the RV, but the disease affects the entire heart. And the one thing that really hasn't been appreciated is inflammation. So if you look at a cardiac MRI here from a patient with rhythmogenic cardiomyopathy, the white are areas of disease involvement. It's really everywhere. And if you look in one of these lesions, there's all sorts of different cell populations that you can imagine. Everyone sees the fat cells here, but there's also fibroblasts, and I'll show you in a second, a ton of immune cells. This is a major, unfortunate killer of soccer players in Europe, sudden death on the field. So this disease is largely genetic. More than 75% of patients will have identifiable missense mutations, oftentimes nonsense within elements of the desmosome, desmogliin, plakophilin, desmoplakin, adherens junctions, and Z-disc components. A lot of this work actually was done here by Jeff Sapitz years ago, who incidentally was my medical school professor and on my thesis committee. And I'll get a chance to work with him now on this project. And so patients with arrhythmogenic cardiomyopathy do terribly. They get recurrent shocks all the time. Many develop PTSD and want their defibrillators out. And the only way to treat them is heart transplantation, which is a limited resource. And you can see here at event-free survival, it really just plummets in young adult years. And we really don't have any good way to treat this population. So if you look at the pathology of this disease by single cell sequencing or these fancy spatial transcriptomics, or simply just immunostaining, these lesions shown here are just chock full of immune cells and contain one of our populations of CCR2 positive macrophages that we're so interested in. And so we've worked with Jeff in his animal models to ask whether this population of cells could be targeted to improve outcomes. And so this is his model where he essentially just put one of the patient mutations in a mouse. And these mice developed the main hallmarks of disease: fibrosis, dysfunction, and arrhythmias. And so this is the model here. The blue is the fibrosis. You can see all the fibrosis between a control and diseased animal. And if we prevent the infiltration of the CCR2 positive macrophages, we see a huge reversion in fibrosis. We see less arrhythmias. This is looking at PVC burden shown here. And red, in blue is control, in red is the animal disease model, and in green is the disease model where the CCR2 positive macrophages were inhibited. You can see that there's many less arrhythmias, and we hit the target that there's also reduced inflammation. So this is, we can get a similar result if we inhibit some of the effector molecules that the CCR2 positive macrophages make, or the translational approach we're taking is using an antibody that prevents their activation. And that's something that we're actually currently designing the clinical trial. And I want to end with saying that this is a paradigm that doesn't just work for MI or this rare disease or rhythmogenic cardiomyopathy, but one that works for lots of different cardiovascular diseases. And some of the ones that we're interested in and been exploring is recurrent ischemia. Most patients don't have one MI, they have multiple MIs. And I can tell you the immune populations in their heart are very different. Immune checkpoint inhibitor myocarditis, major problem in oncology, has its own set of inflammatory macrophages and T cells that can be targeted to prevent inflammation in the heart without impacting the anti-tumor effects. Cardiac sarcoidosis is a major project in the laboratory. We recently defined the immune cells within the granuloma and identified mTOR signaling as being important in their activation. If you actually activate mTOR signaling in these cells in animal model, you can recapitulate the disease. And we're working on translational studies to strengthen the hypothesis and explore the possibility whether mTOR inhibitors like sirolimus or everolimus could be used in patients with sarcoidosis that don't respond to standard steroid and steroid-sparing therapies. And then we're obviously interested in transplantation and transplant rejection, an area that we're active clinically. So with that, I think the main take-home points that I wanted to talk about today are that inflammation can be targeted in the heart, but you got to use precision medicine approaches. You need to understand the immune cell specificity as an important feature and specifically target that. And so among those populations, we found that these CCR2 positive macrophages are important. And if you target their activation, their specification, or their effector cytokines, those could be targets for immunomodulatory therapies. We think molecular imaging could be one way, at least early on, to collect important prognostic information, but also match the right patient with the right treatment. But to really scale that, we recognize you need other approaches like biomarkers. Immunomodulatory therapies can be developed in the academic environment. If I had to share one thing to young physician scientists, that's it. We can do this within our own environment, at least to get it off the ground before partnering. And that arrhythmogenic cardiomyopathy may represent an ideal clinical indication to advance therapies that target these CCR2 positive macrophages. So with that, I have a lot of people to thank. This is my laboratory here on the left. Many folks who are in the back of the room are part of that. I think I've touched on almost every project from every person in the laboratory in some ways. Our imaging group is instrumental in this, our transplantation group with Dan Kreisel. And I really want to give a shout out to Phil Needleman, who made the Precision Medicine Research Initiative possible with partnership with Nate Stitzel and ongoing mentorship from Jean Urbone, Doug Mann, Samant Prabhu, and then Marty Matzuk, who used to be at WashU, now Baylor, has helped us with the DNA-encoded chemistry. And of course, I'd like to thank all the funding sources, including the Longer Life Foundation, to make this happen. And then also want to mention that nothing occurs in a vacuum. A lot of the work that you've seen is the product of conversations amongst different investigators and graduate students and medical students and residents and fellows and postdocs in our laboratory and others within our Center for Cardiovascular Research, which is really among the best in the world. I'd be happy to answer any questions. And I was told if I do not leave this slide up, someone's going to get a lot of bad emails. Thank you so much.
Kory, that was a terrific talk. Thank you so much. We have time for a few questions. Any questions in the audience? If not, maybe I'll start, Kory. The timing of when you do the interventions against the CCR2 modulators, macrophages, I mean, presumably this is not always an acute event. It's a progressive event. So do you see a difference with when you do the intervention? Is there an opportunity when it's too late?
Yeah, that's a great question. So in myocardial infarction, there's a window for sure. The nice thing about our human study is just that window is longer than we thought. You don't have to give it in the cath lab. You can wait till a patient's stable. But the bigger questions in chronic diseases like arrhythmogenic cardiomyopathy or things like sarcoidosis, are there different effects when the disease is starting and progressing versus when it's already there? The good news is in arrhythmogenic cardiomyopathy, these treatments not only prevent disease, but they also can reverse established disease, which is a really important hallmark. Do you see ways to Yeah, so Attila raises the question of whether we can target their inflammatory function, right? Their activation and their effector molecules, is that right? Yeah, so that's the main goal. So early on, we didn't feel that cell depletion is the right approach for many diseases, and that modulating the activation of a cell and its effector molecules may be a better approach that could be more targeted and have a little bit more therapeutic bandwidth. And so in that area, we're developing these IRAK inhibitors to prevent the activation of the CCR2 positive macrophages and trying to conjugate them to antibodies to deliver them to the right target. And then we're working with a few companies in pharma to develop some neutralizing antibodies that target effector molecules like CCL17, which is a chemokine important for bringing regulatory T cells into the heart to suppress inflammation, as well as antibodies that prevent the activation of the macrophages. I think that's going to be the therapeutic that moves forward.
Kory, fantastic talk. Since CCR2 is a chemokine receptor, presumably that receptor is responsible for the migration of those cells into the myocardium. What's making the chemokine that your response? Who's making it? What is?
So when Yokyama is asking, what is the chemokine that brings in CCR2 positive macrophages in the heart? So the chemokines that that the ligands that bind to CCR2 are CCL2 and CCL7. And those molecules are made by a few cells within the diseased heart. So within the human heart, CCL2 and 7 are largely made by monocytes and macrophages that are already within the myocardium. So it becomes a feed-forward process, as well as some populations of endothelial cells. And there's one population of activated fibroblasts. So there's a few different populations that make CCL2 and 7. Interestingly, when we map the cells that make them into space, they all live in the same neighborhood. And so I think those are different populations that are living within these inflammatory niches. So one could target CCL2 and 7 or target CCR2. It's something that we consider early on. However, we also learned that some monocytes that enter the heart will actually differentiate into macrophage populations that are beneficial. And so while we can suppress early inflammation, we were also suppressing healing. And that's why we got very interested in, instead of preventing monocyte recruitment, could we then take the approach of steering a monocyte away from a harmful cell and towards a beneficial cell? And that's the area that we're focusing on trafficking.
Do we know anything about how these CCR2 macrophages are actually injuring the cardiomyocytes and maintaining the development of cardiomyopathy? Whether these mechanisms are more important at different time points than the clinical paradigm of regulation. And kind of related to that is, we use this information to predict the response from both
Yeah, so a few great questions in there. So the first question is, what are these CCR2 positive cells making that's damaging the myocardium? The short answer is they make a lot of different things that are likely each playing a role in damaging cardiac tissue. And each of those mechanisms could be, predominate at different times after injury and may differ based on what the injury is. We know IL-1 is an important cytokine that it does make that can suppress cardiac function and promote fibrosis. So we think that's certainly one of them, but we recognize there's many more, and that's an active area of the laboratory. Your other question, I think, is even more important, right? Is in patients receiving goal-directed medical therapy, are there individuals that have persistent inflammation? Are those people that don't respond to GDMT and would respond to GDMT if we targeted inflammation? And that's exactly where we want to take our imaging probe, to try to identify those individuals. So when you do a trial, you can enrich your patient population with those that are most likely to respond to therapy and not include patients that are going to respond no matter what you do.
The imaging slide that you showed, you mentioned some patients that 3 months life activity. I was just going to ask, are there clinical parameters that you noticed in that small subset that predicted food and activity of 3 months?
Yeah, great question. So the question is, in the small subset of patients that we did, we identified a subset that had persistent inflammation at long periods post-MI. And do we identify any clinical features that kind of correlated with that? And the answer is not yet. The sample size was too small. It was really a pilot study just to show that we could do it. And we're hopeful our new prospective study will be adequately powered to address that question. We're also going to include biomarkers in there. Are there biomarkers that correlate with our imaging findings that would similarly correlate with those clinical events?
Kory, thanks so much.
Thank you.